I'd like to introduce to you Mary Ann Abrams. She is a clinical assistant professor in the Department of Pediatrics at The Ohio State University College of Medicine and GME Quality Improvement Medical Director and Ambulatory Pediatrician at Nationwide Children's Hospital. She led Iowa Health Systems, now Unity Point Health Literacy Quality Initiative, and is developing health literacy at Nationwide Children's. She co-led the American Academy of Pediatrics Health Literacy Project Advisory Committee. Dr. Abrams has presented and published on health literacy-related interventions in real-world clinical settings, training resources, pediatric health literacy, and partnering with patients and adult learners. So welcome, Dr. Abrams.
Thank you. I appreciate that, and I appreciate everyone joining us today, this afternoon. And I look forward to what I hope will be a very productive session. Everybody's sort of out on the periphery, but that's fine. All right, let's see. Here we go. Okay, so let me start with as Dean Schillinger said, it's kind of awkward. You can see this, but you can't see what you're seeing, and you like to think it's the same. What do we want to accomplish in this 1 hour session? I want you to be able to describe and use the Building Health Literate Organizations Guidebook, and to be able to discuss the 10 attributes of a health literate healthcare organization. I want you to come away with at least 2 key health literacy development areas that intersect with those attributes that you can take back and work on in your setting. And I want you to be able to have the beginning of a plan to start taking action as soon as you get home, to advance as a health literate healthcare organization using the guidebook resources. So just quickly, how many, raise your hand, would say you're formally, officially working in health literacy? Probably almost everybody here. I think 10 years ago that might not have been the case. Okay, how many of you are familiar with the guidebook? Okay, so good. Hopefully you can share some of what you've observed from the guidebook, and others will learn more about it. And I like to get a sense of where we are. So I'm breaking your confidence, how confident you are in using the guidebook or actually advancing your organization as a health literate healthcare organization, with 1 being kind of on the low side and 10 being you should be up here giving this talk. So how about the low end? You're dabbling but would like to do a little more? Okay, thank you. How about moderate? How many want to come up here and share the podium? I bet a lot of you would like to and will. Good. Okay, so we aren't going to spend a lot of time talking about the definition and technical terms of health literacy, but I think there are a couple important things that we need as infrastructure. I know that you're all familiar with this definition of health literacy as the degree to which individuals have the capacity to obtain, process, understand, and use health information and services to make health decisions. But what we want to focus on and what we're learning over time is that it's not just an individual attribute, that health literacy is the product of individuals' capacities and also the health literacy related demands and complexities of the healthcare system. So it's an and. So to address health literacy, we need to include improving the skills of the system, not just people and individuals, as they communicate with patients, families, community members, and employees. So that's why we are talking about health literate healthcare organizations. Most of you, I'm sure, are familiar with the 10 attributes of a health literate healthcare organization. I'm not going to go through those in detail, but I do want to highlight those key words for each of those attributes. So they involve leadership, integrating health literacy into safety and quality, the shame-free care environment, creating easy access to health services and information and navigating that well, communicating costs and information about health insurance and healthcare costs, including consumers and families and patients, not just in the, oh, don't you like what we're going to be doing, but in the design and development, and as well as implementation and evaluation of what we do. Preparing a workforce to make sure that they are able to deploy these health literacy skills and interventions. Big focus on interpersonal communication, especially at high-risk points like medications, and to make sure that we close that loop and ensure patient understanding. Talked about the high-risk points like handoffs, discharges, medication changes, and then what we don't ever forget is that materials, whether they're print or online or other formats that are easy to access, read, use, and understand and act on. So those are the attributes. Health literate healthcare organizations at the end of the day make it easier for people to navigate, understand, and use the information and services to care for themselves or their family members. So I had 3 wonderful colleagues as we developed this guidebook, Audrey Riffenberg and Sabrina Kurtz-Rossi, who are here today, and Barb Savage. And we were working on developing a guidebook, kind of describing some of the work that we had done in Iowa that Anna used in our introduction. And at the same time, the Institute of Medicine Roundtable members came out with those 10 attributes. And it provided a beautiful alignment and a framework or structure for how the guidebook could be organized. So we have introductory and background chapters, and then we have key chapters on leadership, preparing the workforce, the care environment, involving populations, verbal communications, and reader-friendly print materials, or reader-friendly materials. And then we conclude the guidebook with a case study that reflecting some work we did in Iowa that integrates multiple, almost all of those attributes in the work we describe in the guidebook. So in the guidebook itself, and in the handout that's online, you'll see kind of a nice table that shows the intersection between each of the attributes and the chapters, and then a little guidebook at a glance. So I encourage you to download that if you haven't already pulled it off the website or the app. And then I'm going to kind of introduce you to chapters 1 and 2 so you know what's in there. Chapter 1 is kind of an introduction to how the guidebook is organized. Each of those substantive attribute-related chapters, it tries to answer 3 key questions. Why? Why should you address health literacy in that particular area? What would it look like if it was a perfect world? What would it look like? What would people be doing? What would services be? What would it be like for the patient experience? And then how? Tools, resources, strategies, actions that you can use to reach those target outcomes. We kind of described 6 principles that we felt underpinned and were fundamental to however you work in health literacy, that it's a universal issue, universal precautions approach, but that anyone can experience low health literacy at any time. It's all aspects of care. It's preventive, it's acute, it's chronic, it's end of life, it's public health, as we talked about this morning, as well as individual one-on-one care. It is fundamental and integral to quality and safety. You have to involve healthcare consumers, whether those are patients, families, adult learners, people who do not speak English as a native language. And don't forget about employees who work with us. They may be struggling with their own literacy or language skills as well. And that it's great to do this, but we all know how frustrating it is when you take things on and then when it sort of becomes the project of the month or the quarter, and then it kind of languishes. So you really do want to think and put thought into how do you make those changes last? How do you make it stick and sustain? Again, chapter 1, it's your guide, your roadmap. You can really start with any chapter. It's not like you have to start chapter 1, 2, and then 3, leadership, and then work your way through. You can start wherever it seems that you can get traction. You don't have to start at one particular place. Each of the chapters can stand alone. They certainly interrelate with each other, but you do want to work in all those different dimensions. You want to be complete. You want to use improvement strategies, whether you use the model for improvement or Lean or Six Sigma or other strategies, as opposed to just trying to try a bunch of things. And you want to build, as you build expertise, build experience, expand either to other areas, other sections and other attributes, and hopefully ultimately end up working in all those areas. And you can't do it alone. You need a team. Chapter 2 is sort of the resource section. It really provides a lot of the core knowledge and evidence and information about health literacy. It gives you, if you're not familiar with it or if you need some more background documents, it describes the associations of limited and low health literacy with health outcomes and other negative attributes associated with low health literacy. Gives you the background data on the prevalence, talks about disparities and how health literacy interacts with health disparities, describes health literacy as an ethical issue, that it's important, it's core to what we do to actually achieve why we all go to work every day. And it also highlights some of the key current trends and system changes that are going on nationally, changes in quality, the emphasis on patient safety and quality, chronic care, the importance of self-management, the increasing prevalence of chronic disease, affordable care-related initiatives, and the emphasis on patient-centered care and patient engagement. And then also Joint Commission and other CMS, other regulatory or accrediting associations, professional organizations that also describe and emphasize and underscore the importance of health literacy. So it gives you a really great body of knowledge and places to go for that information. And again, tethers it into that triple aim of how quality is related to the patient experience, improving the health of the population, and reducing healthcare costs, and mapping that also with those 6 elements of quality that are described by the Institute of Medicine. Okay, so that's the background. What would be ideal if we had more time, I would like to go through each of these chapters, have everybody have a chance to kind of brainstorm and talk about it and report out on each of those topics. But because we only have an hour, a little less than that now, we're going to do a slightly different approach. I'm going to ask you to all do the table discussions now. We couldn't get crescent rounds, so I know that you're in lines, but I'm going to ask you to form 5 groups, and I'll give each of those groups, you don't all have to be in 5 groups, you can be in 7 groups, but we need to make sure we cover each of those topics. So we're going to have those 5 groups focus on those red areas. One will talk about leadership, one will talk about preparing the workforce, one will talk about the care environment, one will talk about involving populations, and one will talk about interpersonal and verbal communication. I'm going to give you a question or two to kind of focus your discussion. I'll give you about 8 to 10 minutes. Then we'll kind of move through, and I want to kind of dip your toes into the water for each of these chapters and ask you to kind of share some of your discussion and ideas that came up in your groups as we move through. All right, and I'm going to set my timer for 8 minutes. And everybody's questions are here? Let's go ahead and you can stay in your groups, which is fine. And now we're going to start to, again, move through. Again, this is dipping your toe in the water. So you get a flavor of what the guidebook has, what it offers, as well as maybe getting even some beginning thinking of how you might use it or what you might be looking for in it. So we'll kind of be going through each of these chapters in order. And since we're recording this session, Anna's going to try to catch you on microphone there. That's what we've worked on. And I know that I would love to spend an hour on each of these topics, but we're really going to try to maybe do 5 minutes max of each of these chapters. So in terms of leadership, we want senior leaders to be champions for clear communication. And what are the things that senior leaders can do? Clearly, they can take the status quo off the table. We're not going to do it this way anymore. We believe that this is a fundamental, important part of our organizational culture. They can get rid of the barriers. They can allocate resources. They can help you develop some protected time to lead a team or to do some health literacy interventions and projects. And they can build will and support in the organization. So what did the group back there, as you were discussing this, that's what senior leaders do, and that's their day job, their night job, their job. What did you think, if you could get a platform with your senior leader, what would you want them to do for health literacy?
Well, excuse me, we wanted them to embrace it, take an interest in it and make it a priority. As you stated, make resources available, have ongoing training, understand the concept themselves.
I'm sorry, understand the concept of health literacy themselves. Good.
Correct. The willingness to implement a program, funding, make it part of the budget. Perhaps link those principles with their mission or vision statement, some overarching goals. Dedicate a champion, someone who keeps it in the forefront, that it's not a part-time job. Use plain language in their own vernacular. Define measures, so there's a continuum of improvement. It's not a one and done kind of a thing. And perhaps as an organization, put it in people's position descriptions that they're responsible to implement this in their role.
That was pretty thorough. That was great. Anybody in the group that had anything else they want to add? I think you hit those nails right on the head. You want them to really vocally identify health literacy and clear communication, as you said, as vital to the mission and the way the organization functions, and use their position to underscore how it relates, I think, explicitly to quality and safety. I don't know that I heard you specifically talk about those two pieces, but since that is so vital and so important, that's a perfect place to marry the two. Not exclusive, but a great place to focus it. To carry the message, not just throughout the organization horizontally, but up, to tell the board, this is important. We want this to be a standing issue, a standing item. We want other leaders who are heads of entities or vice presidents or in charge of different parts of the organization's efforts to look at health literacy as fundamental and part of that work. Allocate time and resources. And I was really glad to hear you say model the use of plain language in their own verbal, their own written communication, and in their speech. And to celebrate successes. There are an array of health literacy tools that you can use to educate your leaders or to help your leaders develop the kinds of approaches that you described, and a lot more detail in that chapter. Great, thank you, super. Okay, moving to preparing.
I think we have one, the other group wants to add just one.
Oh, I'm sorry, I thought you were one big happy family.
No, but we had most of the same things. We just also had building relationships externally, and where was the other piece? Helping to hone in on specific audiences and partnerships with other organizations, and then acknowledge and promote the efforts of the core people that are working on it.
So we talked a little bit about celebrating the successes, but highlighting the individuals and commending them, their work. Did you have a specific external partnership that you all have done or were thinking about that?
We had just talked about partnering a little bit more with some of the materials that we create, using partnerships like our adult learning programs in our communities and using them to maybe test some of our materials.
Great, and to take that hesitancy perhaps off the table. Again, that's something that a senior leader can do. It's like, hey, this is important, let's do this. All right, so now we're moving to preparing the workforce. So it's everyone's job, right? It's not just the education department, it's not just the nurse who goes in after the doctor, it's not just the medical assistant or the pharmacist, it's everyone's job. anyone can be approached, especially maybe someone who looks a little bit more approachable than somebody marching around in a white coat. So everyone in the organization should be able to recognize signs that maybe people don't really understand or that they might need help, to provide clear answers or to find the person who can provide the clear answer. When somebody's looking lost, to offer to help guide them or answer their question or get them to someone who can or take them where they need to go, to convey that question to the person. Not that we want people answering questions that they aren't qualified to answer, but to make sure that they don't say, you'll have to ask the nurse about that, but to make sure that they either are taken to the nurse or the nurse finds out. And to pass what you observe along. So if somebody is finding out that someone is having trouble understanding, let the next person who's going to be helping to care for that patient know. Mrs. Smith needs a little bit extra attention, or this is something that we see a lot. They said they don't really need an interpreter, but in reality they do. So we can say our policy is to have an interpreter for everyone, and they'll just be here if you have questions, or they'll make sure that you understand. Let us get an interpreter. So that's another good example, I think, of making sure that you go that extra mile and ensure people understand. What approaches did you discuss about how you would prepare the workforce?
So no one in our group has actually seen the guidebook. So we decided to take a more operational approach, like what are the steps that we would take to begin with the workforce?
Absolutely.
And so we were just kind of starting with gathering the data and the information to make the case for the health literacy in the organization, and then see if we can develop some champions to begin the peer-to-peer buy-in, and then maybe do some small listening sessions to educate. And we ran out of time, so we said the whole program would then take flight.
The whole program would then take place? Anybody else?
So we took a look at this from the perspective of what are some possibilities that we could do for communications and such. And some ideas were to keep communications simple and accessible, to use inclusive language, and to always use transparency when talking to all stakeholders. Some other possibilities at the beginning, perhaps focus groups, and look into what types of media that stakeholders use. Perhaps some use more videos versus email or infographics. And a great suggestion as well was to be looking at this. You had a question about objections, yes. And a great response was to look at it from the systems approach, to keep looking for solutions and keep networking to continually improve.
Great. One thing that you touched on just in the time since we put the guidebook out is the acceleration of media opportunities, and some of the videos that are linked to in the guidebook are, when we filmed them, they were, you had to get all these machines and set up, and now you can do these on your phone. So being more aware of how you can use social and electronic and digital media to provide these teachable moments or teachable scenarios, I think is a really nice contribution. So we divide in the guidebook sort of in the three categories of sort of the traditional methods that we have for providing education, all the different, standing educational things and skills fairs and checkoffs and conferences and grand rounds, et cetera. But what do you try to do to change that from just a talk or a presentation to make it more grabbing and to help people really get it, to create those aha moments? Making it personal with stories, overline the data. I think, again, we learned that this morning, again, with Dean. It's not the data, it's these stories. And if you can get stories from your setting, as opposed to there was a hospital in New York that had this experience, but looking for stories in your setting or asking people to reflect on a personal experience they had with their own health, the family member's health, or a patient that they observed. Or even if you're really having trouble getting people to think about it, when they were talking to a lawyer or an engineer or their car repair person, to get that empathic personal approach. Because that helps them understand, it helps them want to communicate differently with patients and families, be a little bit more willing to try some of these things that are a little off-putting because they seem to take more time, be more open to partnering with patients as opposed to just saying this is what we're going to do, and again, evolving into champions, which I think both groups mentioned. Also, don't just say, okay, any questions, whatever, but that IHI approach to what are you going to do, what small step or big step by next Tuesday, soon. So what are you going to do, and can you make it concrete? Could you try this reader-friendly handout? Could you try using TeachBack with your next patient who has a certain condition? Could you ask for some feedback on your form from one patient? It doesn't have to be a giant project, but these small tests of change. Another approach is this marketing approach. So say you're trying to really promote use of TeachBack. And this came from some of our colleagues who worked in the pharmaceutical industry and how they approach detailing. Explaining, plan ahead and identify what are the benefits. Ask questions to pull out their feelings. How do you feel when a patient doesn't really understand, or when they don't follow up, or they don't take medications the way you had hoped and wanted or expected them to? Don't let objections frighten you. It really shows that people are interested enough, they're paying enough attention to say, that won't work. So they're thinking about it. And it's just sort of some of the motivational interviewing principles. Restate it, reflect it, give them a moment or two to kind of think about it, clarify and try to address the concerns and support that point and ask them if that makes sense. And again, close with a call to action. Could you see yourself trying this? Would you be willing to try it even once? And can I check back with you next week to see how it went? Follow up, close that loop. And then the third approach, there's some discussion about the tools and resources in a toolkit we developed called Always Use TeachBack, to use TeachBack whenever it's indicated. And those are coaching tools. So you want to build motivation, honor their current work, understand that change is hard. People think they're communicating clearly, that they're using TeachBack, but they really work very hard to provide education, but when you actually observe, they're kind of doing what we've always done. They're providing education, but they're not making sure it's clear, and they're not closing that loop. So you want to expect and understand and accept resistance, build their confidence, foster that new skill development, help them build it into their work habits, build in prompts and reminders and check-ins and check-offs, and realize that when things are busy and crazy, people are going to not do these things 100% of the time. That's like smoking or any other behavior change. You just get back on the bandwagon and keep working on it. Did you come up with any unique approaches to handling objections? I think in the interest of time, I'm just going to point to this, and there's actually a little bit larger section in the guidebook itself. These are common objections. There's not enough time. It's not my job. This isn't a problem in my practice, and nobody can really do anything about it anyway. And what we try to identify is why are they saying that, and then use a tactical response to what is the underlying reason for that objection and try to handle it in that respect. The other pearl I would say is we often spend a lot of time on people who are very resistant. Let them join later. Concentrate your energy on the early adopters, the people that are interested and willing. So focus your energy there, and then we'll talk a little bit more about how to make it sustain and stick later. All right, care environment. 15 minutes to go. All right, we're going to ask each group to report out, but report out quickly. Why we need to change. People don't speak out and say, I don't understand. There's a lot of reasons for that. We know that some people, we talk about screening and whether we should screen or not. Probably not the best strategy and the best way to use our time, so screening isn't the best approach. So this universal approach is a good one. And to think about your care setting, what does it mean to have a shame-free care environment where people feel welcome and feel like they can ask questions?
I'm not sure how I got this, but I'll take it. So we talked about a shame-free environment being all aspects of a care environment, and we talked about hospital, clinic, community, and all the different places where healthcare happens, and that everybody at first needs to be open. That could be making an appointment, that could be front desk staff, and then look like they're ready to answer questions, sit down when they're in the room, and look like they're willing to take questions, and look at navigation across the healthcare system, make sure that all of the places where people are coming into the system are easily navigable, either if that's physically or through the processes of the organization.
We also talked a little bit about the communication with the non-clinical side of it, and we didn't have time to cover all of that gamut, but even within healthcare organizations, insurers, there are people who are clinical and there are people who are non-clinical. And I work for an insurer, so we have a lot of community care workers that go out and do home visits on the high-risk patients, especially those that have frequent emergency room utilization and frequent admissions. And some of them are clinical, but actually most of them are not. And so what they're seeing, they need to have a way to even bring some of their thoughts and concerns back to those of us who are. And so even within an organization, you need to figure out ways to communicate for what everybody is seeing, because everybody's seeing kind of a different part of the puzzle.
That's a great point, and that ties back a little bit to about our own employees. And I kind of emphasize people who may struggle with literacy or language, but there are all these non-clinical people who are immersed in this clinical world and who, A, may not understand what we're all talking about, and second, have jobs that are critical to helping our patients and families understand, and we need to help them navigate that as well. So you guys touched on this. It's how we talk to people, but it's also the setting, and to be able to tune into clues when people don't understand. One of the things that I really like to emphasize and highlight is the hospitality industry. So we're staying, many of us are in the hotel, and just this little bit where if someone walks within 10 feet of someone at the desk, they look up and smile and greet you. Hello. And 5 feet further, what can I do for you today? How are you today? And I think of so many times when I go to the doctor and I'm standing there right in front of the person who's busy, and I know they're busy, but just that doesn't cost any money, right? Zero money. And it can change everything about the encounter and how the rest of that goes. Small little piece, but it's free. Obviously, literacy, language, culture, accessibility, online as well as physical, knowing resources for adult education and ESL in your community, using data, your HCAHPS data that look at the patient experience, and also the ARC Universal Precautions Toolkit has a great assessment for looking at your care environment, primarily in the outpatient setting, but I think you can tweak that. We used the Enliven, which is an organizational assessment. So there are a couple ideas for how to use data to help drive the care environment. I'm going to skip over this. The idea is everybody in the organization should be empowered to stop the line or raise a concern if people don't understand. And this model is using SBAR, which is a patient safety technique where you describe the situation, the background, assessment, and recommendation. And there are several examples in the guidebook that show how somebody who you might not think normally would bring this to attention down the line, how that could be part of your health literacy, your care environment, and your safety work. All right, population served. So health literacy is obviously fundamental to patient involvement. It involves dignity and respect. sharing information, involving patients and collaborating with them to the extent that they want, and specifically hearing the voice of adult learners, people who struggle with literacy as an adult. What did you guys to talk about in terms of how you might involve these non-traditional partners?
So I don't know if anyone else has something like this at your organizations, you may, but we have a patient and family advisory council. So they're integral, I think, from an education standpoint of really any initiative that's going to involve a lot of experience or education from a patient or family standpoint. It's good to run it through that group and really kind of get a reality check on what you're doing. Even with that, I would say that those are more engaged people. And so you still have segments of your populations that are not at that table who you need to be thinking about, but it's a starting point.
We talked about using access to ESL classes to review member materials and get feedback, because the difficulty is finding those more marginalized populations to share information back with us. Another suggestion was to do a type of intake when patients come in, like a 5-minute history. That can be, how do they like to get information, texting, email, what are their pronouns, just a basic 5-minute history of who they are. So that builds that relationship for the care team. Then when we were talking about what success would look like, for us as a health plan, it would be calls to customer service that would be more complex versus simple questions about what is your deductible, for example. And success would look like, in the care setting, active involvement in decision-making. Thank you.
Great. I liked the way you talked about sort of formal committees and the Patient Family Advisory Council, trying to identify ESL classes or maybe adult literacy groups that you could work with and partner with, and also looking at that individual feedback and opportunity to get feedback on a process or a form, and your thoughts about what success would look like. That was very nice. You want to find people who are willing to help. Ask them what they think. Don't just present a done deal and hope that they give it their seal of approval. Invite them to join the team and let them figure out how they can help. Some people can't come to meetings. They have childcare, transportation, jobs. They can't meet at 1 p.m. like we can. So they're often, maybe they're willing to look at a material at home or at night. You can have a work group that people can join. And if you do partner with adult literacy groups, you want to make that a true equal partnership. Offer them something in return. Don't just expect them to show up. They may need some mentorship because they're very uncomfortable coming into a world that they're not familiar with, especially with a lot of technical work and mentoring, and value their participation. So you have patients and families on key committees, care teams. Their stories and recommendations are shared. They're part of your education and teaching. And another opportunity that fits with the care environment is navigational interviews. So you have people walk through and describe how they're trying to find something when they're not familiar with it. And you learn, A, from their participation, and B, how do you make your signage better, your care environment better? Verbal communication, plain language, teach back. We want to have that modeled and used all the time. We want people to be able to raise concerns. Don't forget about interpreters and transitions in care, whether it's a discharge or step down or whatever. Make sure that communication gets handled. So did you come up with some ideas for sustaining and embedding all that work that we know you're already doing to make it last?
We had competencies, education, scripting, recording calls, periodic observations, always keeping at it, it's never one and done, which we heard from other groups, policy changes, audit and feedback, establishing a list of words you don't use with the marketing team or other teams, and then putting that on your intranet, and that incorporating that into your style guide. Employing it in the performance appraisal process, having it a part of an organizational goal, and we we're trying to brainstorm ideas on how you could potentially make that happen, listening for calls and eliminating words and acronyms potentially throughout the year to meet that. Does your Net Promoter Score show measures that people are likelihood to recommend you because they can understand their health better? And then mystery shopping.
We did a secret shopper experience, and it was incredibly illuminating. So yes, great. And I like the style guide piece too. That reaches a different group of people. Anything else? Okay. So there's quite a big section in the guidebook that touches on many of the things that you said. And I'll just kind of run through those to make sure that I kind of highlight all of them. You can think of it as a standing agenda item for key meetings, quality and safety, the scorecards. You can look at communication-related adverse events, and I know Dr. Morrison's going to talk about that in her session tomorrow that I can't wait to attend. Get lay reader review when you're developing materials. Your faculty, med students are learning more and more about teach back in plain language. You don't want them to show up, and nursing students and all of our health profession students, you don't want them to show up and have the faculty say, we don't have time for that. So work on mentoring faculty as role models as well. Recognizing the champions. And this issue of when you're doing community education, how do you engage the community? Teach patients how to elicit teach back. Just a minute, doctor, I want to make sure I understood what you said. Can you go over that one more time? This is what I heard you say. That it's pretty hard to say I can't wait to hear what you have to say and then clarify if it's not correct from the part of the provider. You talked about policies and procedures, performance reviews, job descriptions, building it into orientation, training, required education, observation, feedback, care processes and competencies, and people can work on it in terms of bonus or incentive packages. Have prompts in your electronic medical record for workflow, and provide feedback on the use of some of these tools. And then focus your work on really high-risk situations. I have a couple PDSAs because I wanted to highlight the model that we used. I'm going to skip over those, but those are small tests of change, plan, do, study, act. A couple of these involve use of a plain language document, a handout. One involves a physician trying to use teach back. Again, just to give you the flavor of what it can look like. Reader-friendly print materials, great section on that. It begins with Norma Knoyer, who's an adult learner, who shares her story of an inadvertent medication overdose because she didn't understand what she needed to do in terms of her son's seizure medications. There's a lot of tools and rationale for why we want to use reader-friendly print materials. And finally, the case study involves a reader-friendly consent form that we developed in response to people saying, this is where we want to work, believe it or not. And we worked and partnered with the law department to develop a reader-friendly consent document. We rolled it out with small tests of change. And as you can see, it had a lot of white space, it had large font, plain language, and when we did our evaluation, we had more people feeling comfortable asking questions, more people who actually read the consent, and people who remembered being asked to describe their surgery in their own words, AKA teach back. There's a kind of a summary of how we used that case study, that consent document to match up with each of those attributes. Now, I always like to build in a couple minutes because you can have great ideas and then you walk out and you never get to do it. So it's 3:43. I'm going to ask you to take 2 minutes to use the handout to jot down a couple ideas that you want to use or get started or look up so that you at least have something that you've had a minute to take a note with. And then we will wrap up.
I am going to get my chief quality officer to agree to one measure that's going to go on our harm index.
I love it.
Sure, we have used a lot of champions on various other improvement work that we've done, and I think my aha moment today was having health literacy champions, Andrea. And so this is something we both work at the same organization, and so I'm thinking we have a health literacy task force, and maybe partnering or collaborating with some of our clinics and our department and unit leadership to get some frontline staff, get them the tools and the education and training that they need, and start building that.
And highlight that work. When I was at Kansas City Children's Mercy, they had like Health Literacy Champion T-shirt awards for like those kinds of things. And you can use Health Literacy Month as a way to kind of launch something if you're going to do something a little formal. Just don't let it only be in October, right?
Right.
But that's great. I love it.
And then one of the other things is we do have a resource page. It's located on our hospital intranet. I'm not sure that a lot of people are driven there, and I think we need to kind of brainstorm how we're going to either drive people there or move it so that it gets seen and used more.
Yep. Kind of behavioral economics type things where how do you get people to want to go there? Incentives or a prize? Let us know next time. Okay. Great. So hopefully you now have a sense of what's in here. Thank you for your time and your thoughtful work and sharing your work. And hopefully, I'm not going to have everybody raise hands, but hopefully you've moved up a tier in your confidence level. The book is full of resources. Here they are, and thank you all for your time. Great.